Good afternoon, everybody, and thank you for joining us for another one of our MAG free educational seminars. Today, we have back with us again Dr. Tamara Culnane, Consultant Anaesthetist, and she's going to talk to us about anaesthetic and perioperative pathways. The perioperative period is the moment the person goes into the hospital through to the moment that they leave the hospital. So that's everything that happens to them as part of that hospital visit. I'm going to ask if you could all please keep yourself on mute during the presentation so that any noise from your home or workplace doesn't interrupt the quality of the recording. But at the end of the session, there will be the opportunity to ask questions. If you need to ask a question and you've got to go, you can always type your question in the chat at the bottom, and I'll make sure that the question gets asked on your behalf. You should receive the recording and the slides, if not later today, certainly within a day or so afterwards. And of course, you can always watch our seminars on our YouTube channel, which you can reach by doing a good old Google search for Medico-Legal Assessments Group YouTube, or accessing it through your MAG login using the Seminars tab on the left-hand side on the menu. So without further ado, thank you so much, Dr. Culnane. I'll hand over to you.
Good afternoon, everyone. I'm Tamara Culnane. I'm an anaesthetist in combined paediatric and general practice in the private system in Victoria. I'm going to talk about anaesthetic and perioperative pathways. Now, I'm going to talk about a number of different sorts of documents, standards, guidelines, policies, protocols, procedures, and all of us, no matter what sort of organisation we are attached to, are familiar with organisations having policies and procedures, and generally there's some mandatory nature to these to guide what we do, to streamline and to guide how we as individuals will deal with the same problem according to our institution's intentions. And they tend to be part of onboarding, and they're attached to our adherence to our key performance indicators, useful for audit and quality assurance sort of processes and compliance activities, and also a key point for their development in the medical system is being able to bill Medicare and funds for payment. They're also useful reference points in medical legal reporting, and I often do make sure I update myself on certain guidelines and policies whenever I'm looking at whether their actions or omissions of a practitioner can be considered to be best practice. And that comes right from those sorts of guidelines that might be difficult for people to access because they're contained on intranets of various institutions, to those that might be readily available, which we'll talk about, and right down to the forms and protocols and tools that are seen by us all when we get a medical record to do a medical legal report. So moving on, the utility, just to mention again, it's very, very clear that costs associated with complications are very significant. It's a little bit scary there, thinking that there might be a 5 to 25% complication when you go in for certain procedures. I would emphasise that a lot of those are fairly minor things, but clearly they increase costs. So apart from quality assurance, efficacy and safety, that's been a very important driver of the imposition of so many standards and guidelines on the medical profession. A very big review with meta-analysis in the Cochrane group showed that with clinical pathways, which I'll talk about defining, you can reduce costs. And interestingly, I think that number of 1 in 18 to avoid hospital complication is actually quite a good number. That's quite a significant reduction. The nature of these meta-analyses comparing all sorts of studies with different outcome measures sometimes makes it hard to prove a point. They couldn't show that mortality or readmission were altered by pathways, but it may be just that it's actually difficult to compile those studies. There's a body, the Australian Commission on Safety and Quality in Healthcare, and you can access their clinical care standards really easily at safetyandquality.gov.au. And they have a number of them, not all of them particularly relevant to me as an anaesthetist. And those standards are sort of at the high level of organisations. So they have an epidemiological or an umbrella sort of role to compile clinical evidence and talk about what the best way to manage a certain clinical indicator is. So they address the pathway, but they do emphasise using clinical judgment. And as we go through some of these definitions, you'll find that there's a great deal of overlap. There's a great deal of chicken and egg as to which comes before which. But policies and clinical care standards tend to be for the bean counters and the more administrative end of things. All of the standards, if you do look at any of them on the site, have a bevy of reference at the end of them and make a point of not being a mandatory code. The National Health and Medical Research Council talks about defining guidelines as how something could be done. I mean, that's very loose wording, I find, for something that's being called a guideline. If you just go to a simple dictionary, it'll call it potentially a piece of advice. The Institute of Medicine calls that a recommendation, but that's informed by a systematic review of the evidence. So that gives that a little bit more teeth, if you like. But a high quality guideline needs to be based on really reviewing what's out there in terms of clinical trials, how good those trials are and how good that evidence is, and experts making a decision as to forming a guideline. So general guidance, advice, support, not such a mandatory thing as something like an institutional protocol or procedure. And of course, guidelines have to be quite variable. We'll see later how many different guidelines there are for different things in different places, because biological systems, i.e. patients, are variable and locations, etc., are variable. Now, I'm just putting this in not to frighten you. Please don't try and read it. But the only real guideline on the safety and quality site that's really I've used, because it's fairly specific, is the prevention of venous thromboembolism. So they have a standard that you can readily access on the site. And one section of their references is this, which I've just collapsed in. And so this gives you a sort of a potting of a whole lot of guidelines that are out there, tools, protocols, risk assessments for venous thromboembolism prevention of deep venous clotting, etc. So you'll see there are different countries. There's the UK, there's Nice, there's the maternal, there's the ONG, there's New Zealand, there's the Queensland Health, there's a hospital admission version, etc., etc. So they really have to be specific to your needs, but they do all have common threads. Clinical standards and guidelines that are fairly specific for anaesthetists do exist. I'll talk a fair bit about the Australian and New Zealand College of Anaesthetists, or ANZCA, professional documents, which once again you can access very readily. Some of these documents are once again more for people who are in administrative or other controlling roles, so a guideline on quality assurance, etc. And this guideline 66A, which is a professional guideline on the role of the anaesthetist commissioning medical gas pipelines. Now, I've done that once with a much older version of the guideline, where I was terrified that I was going to cross the pipes and kill everyone with nitrous oxide. But a lot of those guidelines are not of relevance to us in practice. There are some that are very important and very useful that I'll talk about later. I've mentioned the Commission on Safety and Quality and their standards. And I've mentioned that things need to be fairly location specific. There are a lot of different guidelines which you'll find in state health umbrellas or in healthcare jurisdictions, such as a particular healthcare region in Melbourne, or for standalone facilities who tend to have to develop their own protocols based on those of big brothers. Terrified, I was terrified. So clinical pathways, or CPWs, I've mentioned earlier, they started to come into force in the 80s and particularly the 90s. When I was a junior doctor in the 90s, they were coming in force in large hospitals as pathways to give guidance for ward staff, mainly nurses, but also doctors. For instance, if you came in to have your prostate surgery or you came in for an appendicectomy, what to expect. In how many days should you be up and about? For how long should you have venous thromboembolism prevention? When should you be expected to be really coping with eating and drinking and so on? So the standards and the guidelines are, if you like, umbrella documents there with recommendations that are used to write up clinical pathways, and they're more coal-face tools. So translating that pathway or guideline or standard into a care plan or actual algorithm or really quite nutty protocol. They have components including a timeline, as I've said, interventions and activities that you would expect to be happening. They need to be recorded and rated, and an outcome assessment of the progress therein, and a variance record to allow any significant deviations to be looked at and analysed. And so they are reducing unwanted variation in practice, unwanted outlying practice, and also they've got those audit quality and safety additions to what the information that we can gather. Funnily enough, though, they're not actually formally used in so many settings now. And if you ask on boards in various different hospitals and settings about the clinical pathways, they say, but actually, if you do look, they seem to have been replaced by a proxy of tools which are fairly synonymous. These are, again, ward-based forms, and there are a whole lot of laminated reminders plastered all about my work areas clinically, reminding me of certain protocols and guidelines. So if you like, there are umbrellas and breakdowns of clinical pathways. So blood transfusion observation protocols, thou shalt check the temperature, the pulse and the blood pressure every 30 minutes, and timelines as to how long one can do that for, and the antibiotic prophylaxis guidelines, so that we're good stewards of our precious antimicrobial drugs. I'm going to just show you a picture, and you'll be familiar with what I'm about to show you from looking at medical records of the St Vincent's Private Hospital, Melbourne, multiple day, in other words, more than just a day patient, risk assessment tool. Now, this is meant to be used on admission and subsequently for all patients who are staying at least overnight. It's meant to look for potential problems, assess risk, and therefore institute measures to prevent problems such as people becoming confused during a hospital admission, having a delirium, whether someone's at risk of malnutrition, whether someone's at risk of falling on the ward and should perhaps be nursed in a line of sight room or have very much attention to bed rails and other monitoring, skin integrity, pressure injury, and so on. And it's quite busy when you get into the centre of it. It's 6 pages that fold into the file. Now, obviously, if you're used to doing this, you would become very adept, I'm sure, at tick, tick, flick, what's important. But it's a very, very busy tool and quite arduous in terms of administration. And there are many others. Moving on to procedure. So procedure is something that's has a very detailed mandatory sort of list of steps for a recurring task, something that has to be done a certain way. Interestingly, the Anaesthetic College professional documents have some sort of procedural instruction to them, but very minimally, and there's very little that's mandatory in the ANZCA guidelines, as we'll see. So some definitions of procedural tools, intravenous access device, so your IV drip. Nursing staff who might be putting a drip in for you if you're coming in for an iron infusion or for chemotherapy, they have a very proscriptive list to tick, tick, tick. So hand hygiene, gloves, position, tourniquet, test device, insertion device, sort of dressing, patency testing, and then subsequent monitoring. There is a record for medical staff these days. Often my anaesthetic nurse or assistant is filling it in, and it's more a tool for the subsequent monitoring of that device on the ward. Similarly, there's all sorts of forms in the notes that are meant to look at the stewardship of your urinary catheter, your surgical drain. Some very important ones, which again we'll talk about shortly, are tools for intravenous analgesia. So when you're able to give yourself or your nursing staff are able to give you intravenous opioids, and regional anaesthesia such as spinals and epidurals, nerve catheters and so on. Because these carry significant risk, they need extra monitoring, and they should have good, proper documenting and assessing tools. I put this slide in quite late at night for some reason. I must have been a bit tired. So in practice, these guidelines are constantly updated, and it's obviously counsel to perfection, with the amount of medical information that's generated now being hundreds of times what it was on an annual basis 30 years ago. So we do rely on the experts looking at the best evidence and cooking that down for us, distilling it into summaries and algorithms. And I'll talk about some of the sources in addition to guidelines that we find as anaesthetists and clinicians are good to assess, and I find are good when I'm assessing a medico-legal report. So this is an extract from the Australian-New Zealand College of Anaesthetists site, where you can readily see all this. They have a statement that the professional documents and so on are about safety and quality of care. There's an umbrella document which is intended to be read by the public as well as by clinicians, which is about 5 pages long, and it just talks about that there need to be standards and what the standards are in terms of our general management of patients, pre-anaesthetic, intraoperative, post-operative care, and also our relationship to the adequacy and safety of services in any healthcare facilities that we're working in. They have three sorts of documents. So there are policies which are denoted CP. They're actual sort of mandatory prescriptive documents that state things that must be done in a certain way. And very few of the professional documents are actually policies, CP. Position statements describing where the college stands on a particular issue. And so, for instance, there's a position statement on medicinal cannabis, which hasn't been updated for a couple of years. There's a positional statement on, the management of chronic pelvic pain in women and so on. There are quite a broad ranging number of statements, but they are very light in their touch. The guidelines are more helpful to us clinically, and we obviously reference them much more. Denoted PG or professional guidelines, so they're the advice based on best practice recommendations and so on. But once again, they're very clear that they're not mandatory. There's a position statement, interestingly, on the post-anaesthesia care unit or the recovery unit, and this outlines all sorts of things about what you should have in a good recovery unit in terms of adequate staffing who are adequately credentialed, the sorts of equipment you need, oxygen suction, monitoring, what sort of facilities you should have in terms of an emergency, what sort of mandatory contact for an anaesthetist who has left a patient with you, how available they have to be, and so on and so on. It fascinates me that that's only a position statement, not some sort of more mandatory document. There's a guideline for the management of major regional analgesia, which hasn't been updated for a while. That's really, really useful. They're all accompanied by a background paper if you wanted to go down the rabbit hole, which has all of the references and evidence annotated and in fact sort of picked out for you to look at. And we're encouraged to be really familiar with these documents. So what do I do to inform my own clinical practice as well as when I'm then looking at a medical legal question? So obviously my initial training is something that, I can't stray far from. The training of candidates nowadays is obviously very different, but we do all carry that stain. The adequacy of my continuing professional development in terms of my willingness to have a really scope of practice focused investigative look at what I need to be up to date. There are lots of location-specific protocols, as I've mentioned. Interestingly, obviously, I'm influenced by the surgeon I'm working with, and their preferences may vary considerably. And then we talk about these use of other sort of documents, like the professional documents. There are a core body of other things that I'll reference, not only for work, but obviously for looking at something medico-legal in order to see what the comparison to best practice is. And we, for instance, as anaesthetists, have go-tos like the American Heart Association guidelines. They might issue guidelines on how to deal with the blood thinning medication of a person with a valve who has to have that stopped so that they can have a major surgery. The New England Journal of Medicine has a special evidence journal which percolates down things into a really bite-sized, up-to-date information for us. The British Journal, again, has an education wing. The Australian National Council on Resuscitation regularly introduces updates for us. And those are the sorts of sources that we revisit regularly. We do need, though, to treat them as guidelines. And that's where it gets very blurred when we're looking at medical legal reporting, because people are variable. Someone might be very opioid tolerant. for instance, they're on a big fentanyl patch and a lot of morphine for their chronic cancer pain, or they may be quite sensitive because they're a small child who's got severe sleep apnea, has failed to thrive, and so on. The same procedure may vary greatly in its complexity. I once did a locum up in Broken Hill, which a long time ago did not have certain blood products available, and we had a patient who ruptured an abdominal aortic aneurysm, was bleeding significantly, and if we'd opened them up and operated on them in Broken Hill, they just would have bled to death because we wouldn't have been able to replace the factors that they required. So they had to be care flighted off, which obviously, is something that can affect their outcome. And as I've mentioned, there are surgical and anaesthetic concerns, and we sometimes butt heads a bit. Urological surgeons love to use gentamicin when they are doing an operation through your urethra and bladder to remove a stone, kidney stone or something like that, or your prostate surgeries. Gentamicin has very little potential for allergy, but it's not great if you've got kidney dysfunction, and it can have a devastating side effect on your eighth nerve, which is your eighth cranial nerve, which is your hearing and balance. Ceftriaxone is an alternative which has a much higher incidence of allergy but doesn't have these other issues. So we butt heads on people's preferences and opinions. I'm now going to talk about a couple of cases relating to major regional anaesthesia or analgesia, and please don't ever think that you can never go into a hospital again, because some of these things might happen to you. But I'm sure we've all seen such and worse. Now, just briefly, these are major blocks, not like a local anaesthetic block for your skin or a small nerve. They can be the anaesthetic in themselves. So if you're having your caesarean section or your prostate operation, you can be awake or sedated for the prostate and actually not feel much except maybe a bit of touch, pressure and stretch. Sometimes you're off to sleep as well because we've got to ventilate you. You're having major abdominal surgery, or the surgery is going to be prolonged or more complicated. And these things also can give you pain relief post-operatively. So a consultant anaesthetist has a trainee coming into theatre with them. The trainee's just started second year, so they've probably done 3, 4, 5 or more years as a junior doctor, and they're now an anaesthetic trainee. It's a list for caesarean sections, and the trainee turns up after the first block is in and the caesarean is underway. There's a bit of chatting and a bit of teaching. They're not familiar with each other. The second patient for caesarean section comes into the adjacent anaesthetic room, and without much discussion or very prescriptive discussion, the trainee is asked to just go and assess the patient and prepare them. Their intention here would be that they would oversee the previous anaesthetic assessment, put a drip in and report back, I would just expect. Meanwhile, their first caesarean proceeds, and that patient and the baby are taken to the recovery room, the post-anaesthetic care room, by the consultant anaesthetist, and the nurse doesn't come back into the anaesthetic room because he or she has to go back to theatre and sort everything out for the next case. The consultant comes in to find that the trainee is already getting a spinal injection underway and recognises some issues there. Now, we'll see when we look at the professional document, you cannot do these sorts of major procedures without an assistant. You may need extra equipment. There may need to be some supervision and monitoring of the patient. The trainee has also just forgotten to put the drip in, and you'd be surprised. This does happen. Later on, we'll see in the professional document that that's a mandatory thing. You can have significant reactions, quite apart from anything else. Often, if you're a pregnant lady and you're a bit needle phobic and someone's in your back with a big needle, even though you've had some numbing, a lot of people feel faint. And also, the medication that we're injecting is going to alter their cardiovascular parameters, and there's often a drop in blood pressure. And you've got an unborn child that needs blood pressure to perfuse that placenta. The trainee hasn't prepared anything to deal with potential common side effects. I wouldn't even call that a complication. That's just a side effect. They also have failed to have any knowledge of operational considerations. It could take 30 minutes to turn over that theatre in preparation. The spinal block itself will last a good hour, maybe an hour and a half. If 30 minutes or 40 minutes of that is wasted, then we may be putting that woman off to sleep halfway through her cesarean section because she's starting to feel things. So there's a lot of failures there in terms of the stewardship of that consultant, as well as the performance by that junior trainee. The consultant, I'll just flip through this, obviously manages this, and the important things are to proceed safely, but also to follow that up. And there's a risk man system for internal investigation of this. And there's obviously the new open disclosure legal processes that are initiated. Looking at professional guideline 03, the guideline for the management of major regional analgesia, obviously you need to understand the anatomy, you need to understand your drugs, and you need to know the complications of any procedure you're going to do. You need to know what they are, what you would do about them, or what help you would get to deal with them. And you need to make preparation for that. That hasn't occurred. There's a position statement, again, a position statement on the assistant for the anaesthetist. When you read them, they don't sound like they're advisory. They do sound fairly mandatory, but nonetheless just called a position statement, that you need an appropriate assistant, and that's someone who's trained. And anaesthetic assistants and technicians and nurses and midwives are trained. And there's a separate guideline on monitoring during anaesthesia, which applies here. And this person should have made sure that there was an assistant who could monitor pulse, blood pressure, and other parameters. So you could reference those guidelines in making your medical legal report. A patient has a forearm fracture, probably skiing, who knows. They have come down to a busy emergency department after having sort of first aid, pain relief, and a temporary back slab to stabilise their forearm to relieve pain at the small regional hospital, and told that you'll need to go to the big smoke for this to be fixed. The registrar, orthopaedic registrar, sees them in the emergency department and says they need a manipulation under anaesthetic or a closed reduction, which is just fiddling with that bone or bones so that they're better aligned and they can be formally plastered up to heal properly. We wait, the patient is fasted and fed because they keep getting bumped because more significant trauma comes and goes to theatre in front of them. There's an emergency medicine registrar who's had some anaesthesia experience and knows how to do a thing called an axillary block. That's an injection into your axilla or armpit to the nerves to your arm. And this patient has been lying on a trolley in the corridor because there aren't any beds in the crowded short stay of the emergency department. There's some pressure to do something, and they suggest to the junior orthopaedic registrar, who isn't grown up enough to do the major traumas but would love to log in the manipulation for their logbook and would be very happy to do that in the emergency department. The emergency department registrar takes the patient into a procedure room without an assistant and uses the ultrasound machine there, which is fine in itself, but unfortunately injects some of the local anaesthetic into the vein, the large axillary vein. Now, it's not uncommon for that to happen, but if you have an assistant, you can aspirate easily and be more likely to avoid seeing any blood in your syringe. So a failure there has contributed to that. Unfortunately, when you inject these long-acting local anaesthetics into someone's vein, they do two things very quickly. Firstly, they cause seizures and then central nervous system depression, and they also cause cardiovascular collapse. So the patient fits and starts to drop their blood pressure, and in the motion of fitting, their drip comes out, of course. Buggerlugs manages to push the button, and there are enough experienced resuscitators in an emergency department, so a drip goes in. There is a need for an adrenaline infusion, and the patient has to have a lot of Valium for the fitting, and so they need to be intubated because they will then not breathe. I looked at the College for Emergency Medicine, and it's not very easy to access sort of policies, procedures and guidelines on their site. They have got a policy on supervision, which obviously there's a major failure here to accede to that. We can go back to our guideline as anaesthetists. Now, I would expect that someone performing a procedure normally undertaken in my specialty would have similar proficiency in doing that to someone in my specialty. There is a wonderful guideline which I really like, PG09, which is the guideline on procedural sedation, recently updated. And it talks about all sorts of sedationists. So you can see there that's a very collaborative thing, because there are dentists giving nitrous oxide to children and so on. There are midwives doing the same. There are many other people doing minor surgical and other procedures where they may be a sedationist without being an anaesthetist. It's a great document, and it does talk very usefully about all the issues and what should be done and safety measures for that. To give another example of what I'm talking about being commensurate with another profession, many years ago, lots of GPs did lots of skin lesions. They might even do vasectomies or other procedures. As time went on, not only did it become financially not viable for them to be set up to do that sort of work, but medically, they're being held to the same standard as an appropriately credentialed surgeon, such as a plastic reconstructive surgeon, urologist, etc. And it therefore made complications, whether they were reasonable or not, much harder for these practitioners to defend. But I would expect that if you're going to do an axillary block in an emergency department, you would know what you're doing and you'd be safe, commensurate with what I would do. So if you actually look at the guideline on that, on major regional analgesia, it talks about what it applies to. So major blocks, it talks about the nature of the proceduralist who should be doing it and their level of knowledge. It talks about their awareness of and preparation for dealing with complications. Talks again about consent, appropriate assistant we've been over, the minimum facilities for administration of anaesthesia, and that's general, local, regional analgesia anesthesia, in terms of the availability of appropriate monitoring, oxygen suction support, help, etc. And it talks about various things you'd assess specifically because you're doing a major regional block. Talks about intravenous access should be obtained, and so on and so forth. It then talks about your follow-up, your availability, firstly, to actually make sure that the block is doing something. You don't leave the labour ward until you know that your epidural is helping the labouring woman, and that you've monitored long enough to feel that the person is safe from early significant side effects or complications. The environment for their ongoing care has to comply as well. You have to be leaving them in the hands of people that you know are credentialed to actually look after an in situ epidural or a receding spinal block, etc. And it talks about documentation, that there should be written documentation in terms of the continued monitoring, so that there are separate forms when someone has one of these complicated techniques that flag for those caring for them, medical and nursing staff, what we're looking at, what we're measuring, how frequently we're measuring it, and what we're going to do about problems. So it's really kind of bread and butter. It's a really good guideline. I'm just going to talk about one more case briefly. Patient-controlled analgesia. So you may be familiar that you can have a lovely little mate after your surgery, which contains some fentanyl or some morphine or some oxycodone or something lovely, and you've got your own little button, and you can deliver your dose of pain relief directly intravenously. So you've got autonomy. You do not need to wait for 2 registered nurses to be able to go find the keys, which Jill has taken to lunch, unlock a vial, check it twice, open it, bring it, administer it. It's ready to go, it's checked, you can give it yourself. So very useful for more painful procedures, or procedures where you're not going to be able to perhaps eat or drink for a period of time, like a major abdominal surgery. And there are standards, option to vary them, but pretty much anywhere you go in Australia, a standard morphine PCA would be a 1 milligram dose, a 5-minute lockout, and so on and so forth. There are safety features. So if you fall asleep with your elbow on the button, it's not going to keep dosing you. You're not going to get overdosed from that point of view, and there's a lockout. But you do need close nursing supervision, and you do need a whole lot of support. So a 46-year-old woman warrants having a hysterectomy, and her gynecologist admits her to a small metropolitan private hospital to have this done. She has a sort of an interesting anaesthetic. She gets some fentanyl as her pain relief, and she gets quite a small dose, I would think most of my colleagues would assess. She goes to the recovery room, the post-anaesthetic care unit, and she's starting to wake up and immediately saying that her pain score is 10 out of 10. She has high blood pressure and a racing pulse, and she looks very uncomfortable, consistent with pain. And as she becomes a little bit more awake over the next few minutes, she's 10 out of 10. So she needs what we would call rescue pain relief in the recovery room. And she actually has a dose of 18 milligrams of morphine, because it's perceived by the nurses there that little increments of fentanyl are not going to race her there. So she does settle to a pain score of 2 out of 10, but that's quite a large amount of morphine, I would think, for a hysterectomy, that I might give anything from 6 to 12 in total. She was going to have a gentle fentanyl PCA, but the anaesthetist revises this because she's seen to have high opioid requirements and prescribes her a morphine PCA at double the usual dose. She's learning to use her PCA, and in fact the last 3 doses of that morphine she gave herself, and she went to the ward at 4:30, and she continues to use her PCA. She bings the button every 5 minutes, and in the second hour almost pretty consistently as well. So she has hourly observations. She's got no pain. She's got no pain. The next thing to note is that at about 9:30, a member of nursing staff walks past and hears a sort of a funny grunting noise. They find that she's frothing at the mouth and bluish, and she's not breathing very well, and it's a very obstructed sounding breathing. Again, the emergency button is pressed. A second nurse arrives. There aren't a lot of people around in this small private hospital at night. And in fact, the policy of the hospital is there's no junior medical officer or career medical officer rostered except between 8 and 5 during the day. The nursing staff call the anaesthetist, who's not immediately available but comes as fast as they can, and they also have to call 000 for help because they're not managing the airway well. It's not really their wheelhouse, and it is actually the ambulance staff who advise these nurses that they can give naloxone. We'd be familiar with naloxone as the opioid antidote, which is used in hospitals as well as for recreational overdoses. Obviously, most of the notes are post-event, and the anaesthetist writes that everything's good, nothing to see here, and doesn't make any particular recommendations about any special monitoring, etc. If you go to the nursing chart, it's a wonderfully useful tool to help manage a patient-controlled analgesic device. In this hospital, they're not using a special tool, though. They're using a very old-fashioned chart, which just has 2 lines amongst all the other observations for a PCA cumulative dose and a pain score. Having said that, sure, things like the oxygen level, the blood pressure and pulse are recorded elsewhere on the chart, just as they would routinely for anyone without a PCA button. But it's a very bridge record, and there actually haven't been any recordings after the first 2 hours. Now, I don't know what may have been going on this ward on that evening, what other issues may have arisen. Anyway, the patient's terrified about having any further pain relief. She does go home on day 3, and she's expressed significant distress about the episode throughout the admission and subsequently, and she appears to actually have some neuropsychological damage when she is assessed. So how would you assess this? I mean, we've certainly got some information in terms of professional guidelines, but basically a lot of my assessment of this particular case was just to do with practice consistent with peers in terms of the intraoperative choice to dose from the beginning, the interpretation of her high rescue needs of analgesia to require a double PCA prescription might have been reasonable to send her to the ward with a double dose morphine PCA, but not without some sort of caveat such as, can you let me know how much she's had in 4 hours or 6 hours, or a note to self to contact the ward in 4 and 6 hours and see if that's really still needed. There was no naloxone order. That's a standard, very standard basic thing in terms of practice. And there was also a sort of a failure to support this woman and be on her side subsequently. There's some issues in terms of the governance at the particular stand-alone procedure. It may not be that cost effective for them to staff a resident medical officer or a career medical officer. But in terms of that, then the competencies of the nursing staff on the ward to manage an obstructed airway, to administer naloxone, and to have standing orders as a protocol in that hospital that naloxone must be ordered when a PCA is used there, failures there. And again, I guess the competency of that particular staff, not a personal criticism, but if they've been put in a situation where they're not able to manage, that's not reasonable. The patient's education was totally inadequate, and the supervision of her was inadequate, as we'll see looking at a standard. I've chosen this particular PCA local operating procedure from a New South Wales hospital because it's one I'm familiar with, and it trickles down from a standard in New South Wales Health, and it talks very, very clearly about mandatory elements. It's an operating procedure, it's not a guideline. So it talks about the precautions, the staff, the equipment, how things are to be prepared, what the competency requirement of a registered nurse supervising such a patient would be, and talks about how that patient should be educated and supervised. It notes precaution about giving high doses without review. It notes that there is a specific New South Wales Health-based specific tool or chart that actually distills all of the relevant observations onto that chart and makes it very clear in terms of monitoring. So you are looking for how much someone is using, what their pain score is. Are they looking overly sleepy? Are they breathing well? Or is their breath rate slow? Is their oxygen level okay? Are they having any other problems like nausea or itch from the opioid, etc.? And that is a thorough and comprehensive assessment that makes that person safe through use of that form and that procedure. Talks about opportunities to educate the patient well if there's a pre-admission clinic in a larger centre, then you can start that education early. Then when you're commencing the PCA, and I would actually add for mine that I do that when I see the patient before they go off to sleep, and I'm aware that a lot of that information may not be retained, but it should be given because it can then be reinforced and give the person the confidence and the knowledge of how to use the PCA and when not to use the PCA, etc. It also states very explicitly in this procedure that the registered nurse receiving the patient must be able to determine the patient's level of understanding of those principles and their ability to use it. Firstly, are they actually perhaps not cognitively up to analgesing themselves? They're not using this well and they're in pain. Maybe we could prescribe an infusion instead, doctor. They're meant to have that experience and that agency to actually be an advocate for the patients, for efficacy as well as safety. Anyway, that's what I've given you, and I realise that's jumped around quite a bit, but I do find that trying to reference the policies, procedures and tools that a particular location or health service or specialty uses is great for me when I'm trying to benchmark what my gut feeling is and distilling that into a proper medical legal report.
Well, thank you very much, Dr. Culnane. That was actually really interesting and called to my mind a number of the medical negligence matters that have come before us where the issues of supervision post-operatively and choices of medication have actually been part of the subject of the issue. So that's really very helpful, and I'm sure that our legal practitioners listening to this will find that as well. Does anyone have a question that they would like to ask of Dr. Culnane? You can unmute yourself to ask your question. Good. Usually when that happens, it means that you've actually answered the questions in your presentation. I actually have one last question for you, and that is in relation to, you mentioned the use of the chemical that in prostate surgeries that causes the risk of hearing loss. We actually did have a medical negligence matter where that was one of the issues. Is that something that is known to people, or is that a random complication?
Look, it is known, and it's interesting. Look, when I do have a head-to-head about its use, if I'm a bit concerned, it's interesting that I'm often told, oh no, that's not a particularly common problem. No, it doesn't hardly ever happens. But a lot of the statistics and the reporting that gives you those numbers comes from the US, and of course there's a lot of closed claims. And so it then becomes very difficult to say that the low numbers that are reported are actually really as low as stated. And so the cranial nerve, the eighth nerve, you hear, hearing loss is dreadful, but it's also your vestibular component of that nerve, which is to do with balance. And if you've ever seen someone who's had a viral vestibulitis, where you have your head spinning, your eyes moving, incredible nausea, you're unable to walk without holding on to things, it's a devastating complication. And you can inform people in general senses, obviously, that, you know, there are potential complications with all these medications. But I do think that sometimes we need to just judiciously back off and use something that we believe to be safer. Yeah.
Yeah, there you go. There you go. Well, look, I love the memes. Keep up the memes. Everybody, thank you so much for attending today. As I said, the recording should come to you later this afternoon or tomorrow, and we look forward to seeing you at our next session. Thank you very much, Dr. Culnane.
Pleasure.